The world is projected to be in a terrible state, and by 2050, say half of the population would be classified as obese.
Addressing obesity has become need of the hour at this point of time. You could call it a global epidemic.
Welcome to the Odds Fitness Podcast. Today we have Dr. Jasjeet Wasir, who is the Director of Endocrinology at Medanta Hospital. He is also one of our esteemed advisors when it comes to metabolic health at Odds Fitness. We have this one miracle drug which is out there, which seems to be fixing all the problems, all the notions associated with this epidemic called obesity, and closely associated with diabetes and weight loss. Today we'll ask Dr. Wasir if this miracle drug is the answer to humanity's problems when it comes to obesity, or is it just another burden? So let's reveal the truth about this miracle drug. So welcome to the Odds Fitness Podcast, Doctor.
Thanks. Always a pleasure to be with you and taking up this very important topic, as you rightly started off by saying that the projection based on the global health burden study data is talking about by 2050, approximately half of the adult world, we're talking about the entire globe,
Right.
is going to become obese, and about a third of children and adolescents will be overweight or obese by 2050. These are actually projections. Maybe much before that, the way things are dynamically changing, the environment is changing, and all these things happening.
Right.
Maybe that number may happen much earlier. So it truly has become a very important public health problem,
Right.
which needs to be addressed today. And as you rightly said, that's the starting point of virtually 250 diseases and disorders, which we'll briefly be talking about.
Right.
So addressing obesity has become need of the hour at this point of time. So I hope in the next coming few minutes, we'll reflect upon obesity, its health concerns, and talk about the miracle drug, which you just mentioned about. I'm sure everybody would love to hear about it. Yeah.
Right. So why exactly is obesity becoming a global crisis? Why now?
So is it really becoming? I believe it's already become.
Okay.
It's no more a problem, a disorder, a disease of affluence or developed countries. It's a global problem. You could call it a pandemic, you could call it a global epidemic. Now, the roots of obesity, we must understand that a very important fact that a large percentage of how we look, how our body structure is, that is the fat, the muscle, has a genetic bearing to that. So let's presume that your body composition is maybe 50% or 60% genetic. Well, genetics have been the same forever.
Right.
And it will take centuries for those genes to change. So what has changed?
Right.
The simplest answer is our environment has changed. Let's talk about our country. We've got a major socio-demographic and economic transition happening. We're modernizing, we're westernizing. So when I say modernizing and westernizing, we're directly reflecting on the two most important contributors to the obesity epidemic are nutrition and fitness.
Correct.
When I'm saying modernizing and mechanizing and westernizing, what are we talking about? Calorie-dense foods.
Right.
Simply fast foods.
Right.
Why do we call it fast foods? If I'm feeling hungry, what do? I just open up my app, order from one of the food apps, and it's fast to be delivered. The first part of fast food. Two, they've got fast and large amount of calories. Immediate goes into your system and you consume it fast and you feel very hungry very fast. So that overconsumption of calorie-dense foods is one of the contributing factors. So what I just exhibited as a part of modernization and westernization is also I'm using that app.
Right.
I'm not getting up, walking to the nearest market to get my groceries or get the food. I'm ordering it from here. So the physical activity part of it is also going down. There are a lot of plus sides to technology,
Of course.
and this is one of the side which is perpetuating the epidemic of obesity.
Right.
And two other main factors, I'll just briefly reflect on them, is poor sleeping patterns and stress.
So, would you classify these as hidden factors apart from just calories? What are the possible factors that can lead to obesity apart from calories?
So we've got genetics, as I said.
Right.
We've got nutrition,
Okay.
the amount of calories you're consuming, the quality of calories, the timing of calories, quality of calories. The other part is physical activity, and you being an expert in fitness, very well know that what is happening to the entire universe of fitness amongst the entire population, young, elderly, all everybody, what is happening,
Right.
and great efforts you yourself are putting through the media, social media, and your personal efforts from your institution to promote fitness,
Right.
to make people live long.
Right.
So these two factors, and then combined with the stresses and the poor sleeping patterns.
Right.
If you really ask me, one of the biggest contributor is, oh, I'm too stressed.
Right.
I'm too stressed. I've got a deadline to meet. So, you carry your work back home, and even in work, you're burdened with work. You got to achieve those kind of deadlines. You need to be the first, you need to be right at the front. Those kind of things are perpetuating the whole cycle.
Just going a little off track, how do you manage that for yourself since you're dealing with so many patients? And as I can see, our values match. We want to make society healthier. It's one of our core values in odds, and I'm sure that it's the same for you. When you're working towards a purpose, a noble cause, and then suddenly you have these responsibilities. It's a personal question as well because I'm dealing with it. How do you manage stress whilst looking after your personal health? I try and do it to the best of my capabilities, but you're much wiser than I am. Maybe I can learn a thing or two.
Yeah. So we're sharing wisdom with each other. So I'll share you this thing. It has worked in virtually everybody with whom I've shared, mostly a doctor patient kind of consultation. So I tell them, so the question asked to me usually is, why have they gained weight, like you asked? Or they would ask, why are the blood glucose levels not controlled? So I very simply tell them that these are five fingers. And so these are five factors, fine, which are contributing to your either weight gain or your uncontrolled sugars: nutrition, fitness, drugs, sleep, and stress. Ah, yes, you've understood. Everybody understands that. But what's coming next gives them a better insight into what's happening. That insight is the third. Those like who have diabetes are on medication, drugs are stable.
Right.
So that one factor becomes a constant.
Right.
So if one is a constant, the four become variable, and that's the truth. That's the reality of life. Nutrition, fitness, sleep, and stress are changing every day.
Right.
I'll ask you a simple question. Uh, the last so many years of existence, name 2 days which were the same.
None.
None. So these variables are so dynamic. Our nutrition, our fitness regimen, our sleep, stress, and disturbance in any one of them brings about those ripple waves in all
Each other.
Yeah.
Right. And so if you have your nutrition, sleep, and physical activity in check, it can help you manage stress.
Oh, yeah.
Right.
Yeah.
Right.
If you're eating good, you're exercising. So let's talk about stress. If you ask me, what will you put your money on to reduce stress? I would say fitness.
Right.
Enjoy your food and be fit.
Right.
You'll have much lesser stress rather than saying eat very healthy, your stress will go down. I mean, this is just more of a feel.
Right.
And when we exercise, we know scientifically the feel good hormones are really jacked up,
Right.
and you feel very good for very long, and especially if you're exercising regularly.
Right.
The other very important thing here is while managing these things. So we all would agree about the fact, oh yeah, doctor, you told me five factors. So from today onwards, I'm going to follow the best possible nutrition, or I'm going to do a really rigorous exercise program or a fitness program. I tell them, please stop there. Conserve your enthusiasm. We've got 5 factors. Let's put 20% in all of them.
Yeah.
So 20 into 5 becomes 100%. So invest little bit in all these factors and you get a amazingly large multiplied benefit of what we actually require without putting any stress on you.
Because also, you have the ability to have variety, which humans thrive on. You can do some fitness, some variable forms of fitness, nutrition, some variable forms of diets, Mediterranean or your healthy Indian diet or South Indian. You can have a little variety and eat healthy within those aspects and components and lean on each and every modality, so to speak, to make up for the other.
Yeah.
So well said, amazing. Despite all these efforts, why are some people not able to still lose weight or lose fat?
Right. So now we're going a little deeper into the science behind. We've understood why somebody would have a certain amount of weight or excess fat. More scientific way of talking about is excess fat.
Yeah.
Because like maybe you weigh 96 kilograms, but your entire weight is coming from a strong body,
Yeah.
a very healthy body composition, which is a lot of muscles you have.
Right.
So plain weight may not be enough. Excess fat is what drives the health consequences of obesity. Despite all the efforts, we mentioned about these factors which are contributing to excess obesity. The science behind the weight is not a simple mathematical equation, as uh, as we would say that excess weight is because you're consuming excess calories or you're not burning enough.
Right.
If that was true, it was a simple mathematical equation.
Right.
We won't be having this session.
Right.
We won't be talking about newer miracle drugs for weight loss.
Right.
These sessions would never happen. These drugs would never come.
Right.
And the big burden of non-communicable diseases, which is perpetuated by obesity, won't be there.
Right.
If it was so easy. So what happens is we will dwell upon the individual factors, but let's say, and a lot of people who would have tried weight loss would have experienced this multiple number of times, that each time you lose weight, you can only reach a certain limit.
Like a plateau.
Yeah.
Okay.
You can't go below that, but that's fine. But after that, what happens is, despite maintaining the same amount of nutrition or fitness, or maybe greater fitness, you find the weight coming back.
Right.
Weight regain.
Right.
So let's say 100 people uh, get onto a program for weight loss.
Right.
80 or 90 of them will be successful in weight loss, very happy. But then they get stuck. And by the end of 5 years, maybe 5 or 10% would be maintaining their weight at the dot, the amount they've lost. Rest, everybody would have gained weight. And everybody who's listening to us would know, Doc, we started at a certain weight, we lost weight, but when we regained, it went above where we started off from.
Right.
So one cycle is fine. Repeatedly, these kind of cycles happen. Now, the physiology behind that is each body has a set point.
Right.
You have a set point, I have a set point, everybody here in the studio has a set point. The body will make all efforts to maintain the weight to that set point.
Right.
So let's say by curbing calories and burning more by fitness, you lose weight. The body triggers a lot of neurohormonal changes which promote hunger, reduce satiety. That's fine. But what will a person feel? These things happen under the carpet. Their attraction towards calorie dense foods like sugar cravings will gradually start increasing. So, without knowing, you start consuming more calories. It's because of those hormones which drive hunger, which drive pleasure hunger, or wanting or liking to eat. They get elevated. That's one part of it. So, you end up consuming more calories than you really think you're consuming. And the other part is one of the most important contributors of the energy expenditure in the body is the resting metabolic rate. So as you lose weight, the body decreases the energy expenditure.
It needs fewer calories to sustain itself, so to speak.
Yeah. I mean, very simply.
Yeah.
So if somebody burns like 100 calories in a day, 60 to 70 of them is the resting metabolic rate. So most of the calories we burn in a day is the resting.
Right.
Breathing, heartbeat, thinking, all those kind of physiological functions. So the body reduces the energy expenditure. So it kind of, you start gaining weight.
Right.
Despite everything. And that's the science behind uh, not being able to go further down and weight regain.
Right. Of course, there's this physiological aspect to it, but then there is some cognitive dissonance that people are dealing with, that, we have done it long enough, and we are still not going down. Because, in all honesty, I don't know if everybody here remembers Auschwitz. I did not see a single fat, obese prisoner or anybody with excess body weight, and they were starved. They were prisoners. They were not given food for very, very long time. We meet individuals who come and say, okay, you know what, I have a thyroid problem, I have hypothyroidism. I said, are you taking medicine for it? Are you taking T4? Yeah. I'm like, I don't think that's a limiting factor in your weight loss to an extent or to the degree that you know, can't lose weight to a healthy amount. So I think, yes, there is some physiological truth to it, of course. But then there's this huge aspect of cognitive dissonance where people believe that they're giving their best foot forward, but they're actually not. And they're slowly, finding reasons to get back into their previous routines. It's not working out. I'll just take a break for a few days, come back and do it. So I think that's very accurately said, because in our field of practice, we see a lot of cognitive dissonance from individuals and their thinking.
Yeah, you're absolutely right. So I'll twist your question a little bit.
Right.
And open up a new dimension in weight management or obesity care or whatever we may call it, is the role of the mind.
Right.
So there's a bi-directional relationship of mind and obesity or weight gain or weight loss. You very rightly said, uh, if you are well motivated, your efforts will be maintained. However, mostly, I'm not saying in everybody, but mostly, that motivation actually requires results.
Right.
But you rightly said, you're stuck at a certain point. You said, I'm doing everything possible. Right or wrong, let's not judge them.
Right.
But still, no weight loss is happening. And on the other hand, weight gain happens. So what is the first thing happens when you lose, when the motivation goes down, the efforts go down,
Right.
or somebody may just junk all efforts. I don't want to do it anymore.
Right.
It's a stress on me.
Right.
Back to the point of stress, that it perpetuates that cycle going round and round.
Right.
So that's one part of while losing weight. If it keeps on losing, a person keeps on losing weight, the motivation is good.
Right. True.
So that's one part of it. The other part of it is that uh, the drugs for weight loss primarily act by suppressing appetite, affecting the hunger part of it.
So
We'll dwell more about that.
Yeah.
Because that'll just dilute our current
Correct.
discussion. So, and excess weight in itself has an impact on mental health,
Right.
self-esteem, social, personal, professional performance, and body image.
Right.
That's the aesthetic part of excess weight. We've got metabolic parts, we've got the mechanical parts. The mental part of excess weight or obesity is seldom reported, that telling me that, doctor, I have this problem, to me asking them or investigating, is this problem there? Third, addressing those mental health problems, where that cognitive behavioral therapy, which you so very well talked about,
Right.
is extremely
Yeah.
important.
Yes. 100%.
And when you and me are dealing with people, be it fitness or for weight loss, we're generating that motivation. We're doing that counseling,
Right.
and in our own ways, giving them the cognitive support to build up a new neurocircuit to maintain these things lifelong. And that's what we really want.
Right. Right. Absolutely. Wonderfully said. So, Doctor, what's the biology of hunger? Could you please explain to our audience?
Yeah. So, in my experience, all people who successfully lost and maintained weight have really developed great insights into hunger. And obviously, I do share this with everybody who comes to me for weight management or weight management in with comorbidities where weight loss becomes kind of an urgent matter of concern. So it's again, to a large extent, a mind game.
Okay.
And there is an entire universe of hunger, which, if dealt with, is again one of the core areas. There are 4 or 5 core areas of obesity care. Hunger management or addressing hunger is one of them. So again, for everybody who's tuned in, listening to this, we must understand what is hunger. Let's define it and let's see how can we identify hunger in the right way. And like you're smiling, all of my patients do smile when I tell them this very important scientific, but it sounds very easy to do.
Right.
Let's say in a day I have 100 hunger points.
Right.
So I feel hungry 100 times a day. Out of those 100 times, 20, these are all hypothetical numbers for people to understand.
Yeah.
20 times is my body needing the food for maintaining its physiological functions. The function, everything requires energy. So that's the need of my body, which the science calls as homeostatic hunger.
Right.
The centers for the homeostatic hunger are in the deepest area, the most protected area of the brain.
Right.
You can't penetrate that.
Right.
So once the body needs it, that hunger comes. So you would say, Doc, I don't understand that. Please tell me what am I feeling which tells me this is homeostatic hunger. So I tell you, you feel very queasy in your tummy and you say, oh, I'm hungry. You call up home and say that, oh, I'm hungry. Just get the food ready. I'm reaching in 5 minutes. So the simplest dal, roti, sabji, dahi will make you feel amazingly good because the body has received those healthy calories.
Right.
And you're satiated. And once you finish with the food, it goes off. That's homeostatic. So it's it's more of a the body's need with feeling hunger here.
Right.
You have no pictures in your mind. I purposely mentioned pictures when we come to the other 80 part of it. 20 to understood body needing, hunger here, feeding it, dal roti, I'm very happy.
Correct.
The second part of it is the 80%. Now let's connect that to the obesity epidemic. It's this 80 hunger or desire to eat or wanting to eat or liking to eat or I'm not really feeling good. I want to eat. Emotional hunger, binge eating. You open a pack of Lay's chips and you're watching your favorite movie before you know it's finished. That's the domain of hedonic hunger, where the feeling or the desire or the wanting, liking, pleasure eating, sugar craving, sugar rush, these kind of words happen. And through this program, let's introduce a word for everybody to understand is the word food noise.
Food noise. Yeah.
So, uh, so how do I explain that? I put a gulab jamun and a plate of karela here.
Okay.
Which food is going to talk to you?
Of course, the sugar.
So see this is exactly what food noise is, and that's related to the hedonic hunger.
Wow.
So what am I supposed to feel in those 80 times? How do I differentiate what it is? I'm wanting to eat a burger or a pizza. So I have defined the word pizza or burger in my mind and there is a pictorial of a burger, I'll do whatever it takes to get it.
Right.
Now, with the homeostatic hunger, I just called up home and said, I'm hungry.
Right.
I want to eat something because I'm feeling something here. Hedonic hunger you feel here.
Right.
You have the picture of the food. And that's the main area where the newer drugs for obesity care work. They take care of that sugar craving, that emotional eating, that wanting, liking. Then food becomes nutrition. Then I will be giving my body what it actually needs, proportionate carbohydrates, fats, proteins, fibers, and all those things. So that's the universe of hunger.
Right.
And the smallest part of it, so I'll spend the least time on it, is executive function.
Right.
You have the gulab jamun in front of you, and you say, no, I don't want to eat it today. You'll do it one day, you'll do it 2 days, third day, it crashes, and then let me have four of them. So that's the universe of hunger, which these drugs actually address the 80% part of hunger.
Can you manage hunger?
Yes, you can.
Why should one manage hunger and have a strategy to manage hunger instead of just, I don't want to eat that gulab jamun, I'm going to eat Karela? How do you program your executive function or your neural pathways in a way that is there a way to do it, or why is it
Absolutely.
important? Yeah.
Yeah.
Okay.
So you're very right with that. However, it takes a lot of efforts, and that's what cognitive behavioral therapy is all
Yeah.
about.
Yeah.
So our emotions, our thoughts, our environment, all are triggers for hunger, for eating, our choices of food in a particular situation. So they run in a particular manner inside the brain, involving the most, the highest and the lowest areas of the human mind.
Right.
So there is a lot of stratification in the mind. So it runs through those areas where, if sitting right here inside the studio, I get a whiff of butter chicken, I start salivating.
Right.
I start, visualizing, I want to have butter chicken,
Right.
even though it's not in front of me.
Right.
How did that happen? These are the neural pathways with inside those chemicals,
Correct.
which where already I'm feeling good about the fact that I'm going to be having that food.
Right.
So these are preset circuits in the mind. Now, cognitive behavioral therapy, what it does is it helps, it creates what we do, what we say is neuroplasticity. That now I'm going to make an effort, I'm going to do 20 push ups 5 times a day, I'm going to build my biceps, right?
Correct.
That's what you do.
Right.
So, same way, we're building those circuits in the mind. It then becomes a habit of, it becomes easy to say no.
Yeah.
But it requires lot of efforts.
It does.
And in today's date, uh, generally we desire comfort, convenience, durability, and fast results.
Right.
That's why cognitive behavioral therapy as a solution to hunger has not been very successful, but it's very important.
So I'll give you a little insight into what we do at Odds. We try and call all of our clients athletes. We label them. And by labeling, because I have deeply studied psychology, especially team dynamics, sports psychology. We had this entire module where we would label people as athletes. We would reward them on certain behaviors which will help them identify more with while being an athlete and their physical fortitude, their ability to perform, um, self-preservation, looking at their health, looking at food as a means of nutrition, as to make them the best version of themselves. And we try and use some of Abraham Maslow's things, where we try and help people to reach self-actualization and truly potentiating themselves. And we come to a conclusion where we actually produce exercise lovers. And in a way that totally resonates with what you're saying, which is CBT for a lot of individuals, because we are creating new neural pathways to create rewards for actually looking good, being healthier, having a positive outlook towards the future, being able to look 5, 10 years down the lane, and not get carried away by, let's say, cheap dopamine, cheap dopamine like, social media reels or fast food or something like that. But yes, of course, like you said, it's very tough, and there has to be some level of um, contemplation in the mind to initiate that movement. A lot of people are not even aware that such sort of thing is possible. But rightly put.
No, absolutely, absolutely right. Let me just add. So you said it so beautifully. This is exactly what even we do in the medical part of health and wellness. So very simply, it requires repeated efforts. It requires rewards. Few are those people who actually are not looking for any rewards or results, and they are self motivated. They're the ones who neurocircuitry works very differently. But for most, those rewards are important, and those rewards are actually results. It could be in the form of what you said, calling them athletes. It's so motivating. Somebody tells me that, oh, you're looking good, you're looking like an athlete. That dopamine rush has already happened.
Right.
Whether I exercise or not, that's already happened.
Right.
And how common is love at first sight? It doesn't happen
Right.
mostly.
Right.
You have to be in a relationship. You have to nurture the relationship, and then you can say, yeah, yes, I'm truly in love.
True.
It's that effort. So same thing is applying here.
Right.
That expression of those efforts come from nutrition, come from fitness, come from better sleep, and techniques of minimizing stress. So yeah.
Right. Okay, so the hot topic, this obesity miracle drug. Half of the celebrities, or maybe 80% of them, are probably using, and all of that. No speculation. What is Mounjaro?
As a physician, as a doctor, and a scientist, I would rarely use the words magic or miracle while discussing a treatment. But the truth is, all of those people who have experienced the benefits of any drug, here we're talking about terzepatide, which is brand name Mounjaro, they come back with certain results, which I'll share with you. A lot of times, these drugs, and they're not new drugs, they're just enhanced drugs. They come back with this expression of, doctor, this magic has happened, this miracle has happened. I, I've been wanting to lose weight for so many years. I've made so many attempts to losing weight, and each time I would lose weight, I would regain it back. But now I've lost this much amount of weight, and I'm maintaining it. So to a person, that's magical. That's a miracle for them because they've been repeatedly through the cycle of trying to lose weight with honest efforts, with persistence efforts, but not getting results. And the weight coming back always deters them. They lose their motivation. So in that, I would agree with you when somebody comes to me and says, oh, it's magical. It's a miracle which has happened to me. But as a practicing doctor, while discussing in those who would require a drug like terzepatide or Mounjaro, I would never use such words because it may give a false sense of surety or guarantee that this has happened. So that's the way I would understand that. I would respect somebody who says that it's magic, it's a miracle, but not at the first point. I would project that to a patient. But still, since you asked this question, and so many people do come back who've been on semaglutide earlier and now who are on tirzepatide or Mounjaro, claiming it to be a magic which has happened to them. Let's see, is there science behind it which supports the claim of a person that it's what magical for them? Well, first of all, scientifically, it's it's a polypeptide, it's a protein molecule, which usually, as we would believe, that okay, one molecule will go and attach to one place and have its effect. Well, this is the novelty of this molecule is the single thing attaches to two of the receptors which are majorly involved in weight gain or weight loss. These are the GLP-1 receptors and the GIP. So number one, novelty. Uh, and which is directly related to the reason it is so effective. The second part of it, we dwell on just two very important aspects from a patient's point of view, the weight loss part. To put the science in a very easy language, is till date in our country, there's been no drug approved till now, which is so effective in helping most people lose the amount of weight that happens with this drug. I'm talking about the weight loss starting as soon as 4 weeks and over long-term usage on higher doses, people losing 20% of their weight. Just imagine somebody starting at 100 kilograms and with nutrition, fitness, sleep, stress, and this drug coming to a weight of 75 or 80, which comes to about 20%, can be called as a miracle by the patient. And I would not say no to that. The second aspect, it also has benefits in blood glucose control. When I would say to you that there've been studies where a subgroup of the population who had diabetes were on these drugs, 1 out of 2 of these patients achieved HbA1c of less than 5.7%, which medically qualifies as pharmacological remission of diabetes. See, while I was talking, you uttered the word wow. So maybe all those things are those the results which science has talked about Mounjaro or tirzepatide, and what patients are experiencing and now will experience more and more as it has been introduced in our country. Uh, so that gives kind of a justification for the magical or the miracle effects on metabolic health of our patient.
So, could you explain how is it different from its previous versions? Like um, there's liraglutide, and now we have tirzepatide, Mounjaro. How would you say that these range of drugs have sort of matured into or developed into, let's say, more effective or finer? Is there a difference? Is there truly a difference, or is it just branding, so to speak?
Yeah, so let's dwell a little bit on the science part of it.
Yeah.
So as I said, it's the novelty of this drug starts from the fact that it's a single molecule getting attached to two receptors. We will talk about its affinity to one or the other, but very clearly the benefits of this drug on two aspects, which everybody listening to us is wanting to know. One is weight loss, other is sugar control. We talk about other benefits of the drug. uh, it's it's a combined benefit of the drug interacting with these two receptors. Correct. So we have a single receptor drug and we have a drug which acts on two receptors. That's not the end of the story. Now, very soon in the near future, we are looking at triple receptors. We're looking at 4 receptors, and I don't know how many we're going to go to. So, with each escalating level of these receptor stimulation or blockage, the potency of these drugs is increasing. And some of the drugs which may come in the near future are promising weight loss, which are going to be nearing that which is achieved with bariatric surgery. So, going a little deeper into how it acts. So the GLP receptors and the GIP. Let's first talk about the GLP, which we've known lots about, and everybody who's listening are aware of words like liraglutide, Victoza, semaglutide, Ozempic, Wegovy. They would know about these drugs. So primarily, the first site of action is the brain, the hunger. It reduces hunger, it increases satiety. So you have little bit of food and you feel that I'm full, and food does not talk to you. The food noise we talked about disappears. So when you're in a party setting, a lot of calorie dense food usually talks to us. The noise of food disappears. So saying yes or no to food becomes easy. The sugar cravings, another aspect of calorie dense foods, will disappear. Emotional eating, binge eating. I'm happy, I want to eat. I'm not happy. I want to eat.
Right.
There is nothing I want to eat.
Right.
Fine. So all that content goes. That's the central effect of the GLP-1. Lot of neuro chemistry involved in this. Won't go in the details of that. But how it's working, what people would experience is important to share. The second part would be the stomach. Again, the GLP-1 driven, partly by the GIP, is that it decreases the stomach emptying. So rather than if I normally eat four rotis, after one and a half, all the content is in my tummy and I feel that, oh, I can't have any more. That's the other part. So these are the two main ways it takes care of the calorie restriction and weight loss.
Right.
Entering into the diabetes domain, both the GLP and the GIP receptors together, it's a complex process there, but I'll make it very simple. They help in the pancreas to produce more insulin,
Right.
which helps in blood glucose control. And on the other hand, the kind of anti-insulin hormone glucagon, it suppresses it.
Right.
Now, the GLP, GIP balances out, one may increase, decrease, but the net effect is the anti-insulin hormone glucagon goes down. More of a theoretical.
I've heard it helps replenish beta cell health.
Animal models, yes.
Yeah.
But there is an indirect way to that. If I control somebody's blood glucose levels, the adverse effect of those blood glucose, high blood glucose on the pancreas, what we call as glucotoxicity, gets knocked off.
Right.
And in animal models, it has been shown to provide beta cell protection, decrease its timed death. But these are more experimental things.
Right.
Because if we had a solution like that, we may be looking at a cure of diabetes at this point of time.
Yeah, that's why I asked, because
Yeah.
that's how these drugs are evolving at some point, which leads me to my next question.
Oh, I haven't finished.
Oh, sorry.
So
Yes.
there's one part. So we left the GIP brother away from the picture.
Right. Right.
Now, GIP has got similarities in these effects, but where it has exclusivity is its effect on the adipose tissue. It increases or changes the blood flow to the adipose tissue. It betters the metabolic milieu in the adipose tissue, better utilization, storage of fats, better processing of the lipids and everything, which is again a corner part, a central part of the health impacts of obesity and the cause of obesity. So this in total is the entire reason or the metabolic benefits of terzepatide or Mounjaro happen.
Wow. Wow. We talk about the weight loss effects of it. Does it spare muscle? If you could shed some light on that.
Yeah, I was really waiting for this thing with your bulging biceps. This question had to come. Very right. That any and every effort towards losing weight leads to fat loss. It leads to water loss, another contributor. Call it a silent bystander or collateral damage is loss of muscle mass. Any and every strategy that does not exclude terzepatide or Mounjaro. However, in the clinical trials, I'll just quote a piece of data over a long period, nearing about a year and a half. These patients were able to lose in excess of 30% of their total body fat. There was a very significant reduction in the internal fat or internal abdominal fat, what we call as visceral fat. That's the part of fat which is very metabolically volatile. That's the fat associated with cardiovascular diseases, causation of diabetes, causation of cancers, and on those kind of things. That also significantly reduces. However, there is a numerical reduction in the muscle mass up to about 10% loss. See, overall, if you look at a human body, the total amount of fat of muscle is not as much as the fat. But for health, what we require is lesser fat and more muscle.
Right.
So yes, there is some amount of fat loss. However, the health benefits do indicate that it's the fat mass loss which is promoting the health benefits. and the muscle loss may not be clinically important at this point of time. I'm going slow and I'm stressing on each word.
Right.
Brings us to the solution. Anybody and everybody on weight loss medications, including Mounjaro, must indulge in a high protein diet to prevent that muscle loss and should indulge in fitness, which is where you come in.
Resistance training.
Yes,
100%.
absolutely.
100%.
And that is the real bet.
Right.
We've got the most powerful drug on planet Earth for weight reduction, quote unquote. And we've got you come into the picture, helping them maintain that muscle mass. So what health index is going to come out of that is people are going to lose more amount of fat, they're going to lose less amount of muscle, and they will end up with better health indicators. That's a win-win situation.
That is. Which brings me to the next topic, that if it is exactly how you're saying it, Mounjaro could be a longevity drug.
There is no data till now.
Yeah.
However, if you go at the company's website, they have an ongoing study where they're looking at mortality and morbidity in people who were giving this drug for weight loss. These are possibly, I think, they're non-diabetics, and they're looking at their outcomes over a period of 5 years. So I hope when the study ends, which is going to be in the near future, and the publication comes out, that is going to be actually a very important data till now. That we've had extremely large amount of data talking about weight loss, reduction of cardiovascular risk, reduction or remission of diabetes, all those kind of things. But data about mortality and longevity is still not lacking. So this particular data where nutrition, fitness, and tirzepatide have been used together is going to be very, very valuable in that longevity part of your question.
Right. Because the hypothesis would be, if you limit hunger, therefore you can eat lesser. Caloric restriction with adequate nutrition in place has shown to have some longevity benefits in some processes, considering autophagy, lower consumption of, carbohydrates, lipids, which can lead to better health outcomes. That plus, when you talk about longevity, like you said, mechanical health is very important because you need great health span to be able to do the things that you want. You are actually supposed to be mobile. So I think the hypothesis of such a study, or like from where I can see it, works on hunger, manages how our metabolism is, enhanced, how it makes the body better at a systemic level as well overall. I think it's amazing. Right?
So maybe extending this part,
Right.
just going back to the first question you asked about the magic, the miracle part of tirzepatide, it'll be interesting to understand some of the data around about weight loss. Whenever somebody loses weight, there is a linear relationship on the quantum of weight and the health benefits. For example, somebody loses 3 to 5% of weight from their current weight, they would get some betterment of their blood glucose levels. Taking an example of pre-diabetes and diabetes. Prevention of diabetes will require about a 7% weight loss. Easily doable. And then as you increase the weight loss percentage, let's say 10%, you see benefits going beyond sugar control, going on to cholesterol, going on to blood pressure lowering, slight effects on the liver. You reach 15%, there the world is changing suddenly. You talk about remission of diabetes. People, you start at 100 and you reach about 85. There is a high chance if you have a shorter duration of diabetes, you might come off all medication and just be on maybe just the lifestyle or drugs like tirzepatide to maintain your weight and your sugar levels without taking anything else. 15%. When you go further on, like 20% or 30%, the benefits keeps on increasing, and the domain of benefits goes on to morbidity, mortality, heart failure, all-cause mortality. In fact, remission of non-alcoholic fatty liver disease, or fatty liver as we commonly call it, there's a direct linearity about the benefits. Putting this scientific data into work with terzepatide, so one, the the benefits start appearing very fast, like in a month. About almost all people on this drug, I would say maybe 95, 98% will lose 5%. Now we have a memory of 5% equal to better sugar control. More than 10%, about 80% of people. So out of 100 people on this drug, 80 of them would have lost more than 10%. Then we have numbers of 15%, about 70, 60% of them see the quantum of weight loss, and about 40% of them would lose like in between 20 to 30% weight loss.
Wow.
Not all of them.
Right.
So if you ask me a benchmark number that terzepatide can actually help people lose, I would number it anywhere in between maybe 14 to 22%.
Right. Right.
That's the kind of thing.
That's amazing. Because I see that whenever we're dealing with fasting, because we talk about hunger, caloric restriction, all those things which are associated with, let's say, better metabolic health overall, less visceral fat, better liver, better organs, better glucose uptake, better metabolism of fats, lipids, carbohydrates, all those things, all processes running smoothly. The only limiting factor to a long life would be lowered immunity, instability, where, a person could fall and, hurt himself. So there comes the role of great muscle health. And if you have a strong body, if you have all your nutrients in place, if you're eating correctly, especially when you're dealing with a drug like this, or otherwise also, if you're a small eater, if you have all your nutrients in place and you exercise, have physical activity, you have a robust immune system. So infectious diseases also are sort of taken care of. So I think the way you mentioned the numbers looks after metabolic diseases and lifestyle illnesses. The only thing that we are left with is probably infectious diseases and frailty, so to speak. Is there a safe way for quick weight loss for special occasions, like a marriage or a party or something?
No.
No.
I mean, as simple as that.
Huh.
See, we need to be responsible. In no ways should we ever promote it just for one reason.
Yeah.
If you really need to promote it, let's promote it for wellness. I'm not even saying health.
Right.
I'm saying the full package.
Wellness.
And wellness is lifelong.
Right.
Wellness is not a 3 month stopgap.
Right.
It's a lifelong journey.
Right.
So that requires all the important pieces to be put together.
Right.
And I keep on repeating the same thing: nutrition, fitness, drugs, if required, sleep and stress.
Right.
That should be the full package of wellness rather than a stopgap.
Right.
So essentially, my answer to that would not be used.
Shouldn't be used. Of course, I would double down on that. What would be the clinical guidelines for using it? And how long should patients realistically stay on this medication? Considering that I've heard that some people who wean off and get off of it because they haven't really changed their environments, etc., dealing with hedonic hunger by themselves. Of course, you have the motivation of losing weight, but considering the fact that they might be exposed to those lifestyle factors again, it's not like just because you've taken Mounjaro, now everything around you, the external stimuli that actually led you to that lifestyle has actually changed. So what would you say about that?
So that's a very vital question. And see, because it is so important and that you asked it, the drug trial program also kept this question in mind. So they did a trial in which the initial period, the people were on nutrition, fitness, and terzepatide. They lost weight. And a part of those people, they stopped the drug, the weight started coming back.
Yeah.
Obviously, they followed them up for a limited time period. But the same people, if you would follow them up for longer, they would reach the place where they started off from.
Right.
And like in clinical practice that we commonly see, they would be going or crossing where they started off with.
Right.
However, one very important thing coming out of that is that uh, being on these drugs also gives you an opportunity to rewire your mind. Saying no to food or making the right food choices becomes easy. I don't have science behind it, but we do have experience in people who have successfully reduced the doses, and some of them have weaned themselves off. Yes, they did gain some amount of weight, but they kind of understood what needs to be done and are performing very, very well off the drug. But at this point of time, if you talk about a blunt answer of how long, well, these drugs are intended for long-term use. Diabetes does not get cured. Weight always comes back. So it's a journey and requires long-term or lifelong treatment.
So it's safe to take lifelong?
We have a lot of experience coming from the clinical usage of these drugs and the randomized control trial duration of exposure in patients. So these are extremely safe drugs when used in the right indications, at the right doses, in the right ways. You'll get the success.
Right. Lastly, I would like to ask you, are there any side effects? That's
Yeah. So whenever you flip a coin, you always have two sides. Well, I put it in this way that both sides can be winners. The patient's expressions about a miracle or magic. We talked lots about the scientific aspects of it. But I always believe as a healthcare professional that the skill of using a drug also comes by the fact where not to use a particular drug.
Mhm.
That is what we call as contraindications or patients where a problem may happen or it should not absolutely be used. So very simply, there's a specific type of thyroid cancer known as medullary carcinoma of thyroid. A syndromic part of that is MEN2 syndrome. These two situations contraindicated not to use. Now, rest of them are my personal practices of prescribing GLP based therapy, and obviously these dual receptors, including terzepatide or Mounjaro, would be anybody who's had a past history of pancreatitis. There would be some discordance. Some would say no, you can use, or no, you can't use. But my practice is somebody who has an active gallbladder stone. I may get some critique about saying this, but I would not use it in those patients because rapid weight loss. Some of the patients who would have this can aggravate the gallbladder stone. There have been conflicting views about use of these group of drugs in patients who have advanced eye disease requiring intervention. That's the other condition I would not use these drugs in. And people who have significant stomach issues like lot of reflux, uh, chronic loose motions, and those kind of things. Be careful. It's not a contraindication, but be careful. Coming to the side effect profile of it, it's important to know what a drug is likely to you're going to experience on this drug. So when we started using these drugs, initially a part of making people understand, sometimes we may miss telling them that you lose your appetite. So just imagine you go to a doctor, you're kind of fairly fine. Yes, you have a weight problem or uncontrolled diabetes. The doctor prescribes a drug and within a few days you stop feeling hungry. What is the first knee-jerk reaction you feel? That the drug has adversely reacted on you. It's important to make it a part of the medical communication in making people understand that if your appetite is going down on this drug, that means you virtually guaranteed that the drug is going to work. That's where the hunger is going. The food noise is disappearing. The sugar cravings are now becoming lesser. Saying no to calorie dense food is going on. So that's one part of the effect which may at times be taken as a side effect. Otherwise, nausea, vomiting, reflux in the initial part of the journey. But we've got amazingly large experience on using these drugs in different doses, in different schedules to get the patients through them. Lower gastrointestinal side effects like diarrhea, that at times becomes very stubborn and may require discontinuation. So these are the kind of common side effects that everybody should be informed about.
right. Right. Okay. I think we are done here. Thank you for your time, doctor. I really appreciate it. I always love having these discussions with you because We resonate with each other's ideologies so much. And thank you guys for watching.